Hi, Susan, can you hear me and see me?
Yes.
And do we have Dr. Merman?
I was just looking for that. I don't see him on the list. I can give him a text to see if we've got any difficulties getting on.
Okay, let's do that and we'll give it a minute.
Dr. Foster, I see Dr. Merman has arrived.
Sorry about that.
Oh, great. Well, it looks like we have everyone, so I'll call to order the Green Mountain Care Board's hearing of January 17th, 2024. We have two agenda items. We have a monthly update on the AHEAD model and global payment development. Michelle Degree will lead that discussion. She's our Health Policy Project Director. And we'll be hearing from Pat Jones, the Interim Director of Healthcare Forum at AHS, and Shule Garovich, our consultant from Mathematica Policy Research. And then later on this afternoon, we'll have an update on Act 167 and the Round 1 Community Engagement for Hospital Transformation, which will be led by Marissa Melamed, our Associate Director of Health Systems Policy, and we'll hear from our consultant on that work from Oliver Wyman, Dr. Bruce Hammery. So I'll turn it to Director Barrett for her Executive Director's report.
Thank you, Chair Foster. I want to let everyone know that yesterday the board submitted its 2023 annual report to the legislature. That report is located on our What's New page. It's also located on our website under legislative reports. It's lengthy, but it's actually, I'm always so impressed at our team and what we accomplish every year. And I just want to shout out to the entire staff and thank you for all your work and also the contributions to the annual report. I also wanted to let you know that there's two ongoing public comments, which are very relevant to today's board meeting. The first one is an ongoing public comment on a next potential all-payer model with CMMI. As I've mentioned in the past, AHS and the administration are leading the negotiations on this model. So when you send us public comments, we send those over to our colleagues at AHS and share them with them. We also have an ongoing public comment period on the community engagement work in Act 167 of 2022. At the last check, we had 94 comments on that work, so keep them coming. We love to get that public input from all of you. And then scheduling this evening, we have a primary care advisory group meeting. We'll be hearing from Pat Jones again, Interim Director of Healthcare Reform, and she'll be joining the PCAG and discussing the AHEAD model and the NOFO, similar to what she's sharing with all of you today. So with that, I will turn it back to you, Mr. Chair.
Okay, and we have some meeting minutes to address. They're from December 20th, 2023. Is there a motion to approve the minutes?
So moved.
Second.
All those in favor of approval, say aye.
Aye.
Aye. I didn't hear Dr. Merman. Did you vote, Dr.
Yes,
Merman?
sorry. Yeah. I agree.
I'll take that as an aye. Okay, the minutes are approved. And we'll turn to Michelle Degree to walk us through the head model. Before I do that, though, I wanted to flag that I'm going to take public comment after each section of our presentations today. So it's possible that we have an executive session, and Ms. Degree will talk about that, but I'll try and take public comment after the public portion of the presentation, so people don't have to wait if there is an executive session. And we'll try to make sure we get as much as we can done before that. So, Ms. Degree, I'll turn to you.
Thank you, Chair Foster. I just want to, can you all see my screen? Yes, and obviously you can hear me because you're nodding your heads. So today we are doing a pretty robust update covering two topics, primarily the AHEAD model and global payment development. Typically during these, you have a staff update from me on the board's kind of staff processes with the global budget tag work group. Since we haven't had one of those and we don't have another scheduled until February, my portion of this will be very short today. And as Chair Foster noted, there is the potential to enter into executive session in the event that any of the questions or comments would relate to possible or potential negotiations with CMMI or CMS on a future AHEAD model agreement. I think we're all aware that at this point the state has decided to apply for the model. That does not mean that we will be selected or enter into negotiations necessarily, but in the event that happens, we want to make sure that we can have these conversations. And so I've pulled, well, thanks to our general counsel, got some information here on the screen for you in the event that we do decide to go into executive session. Just a couple of notes. It will need to be, there will need to be a motion to enter into executive session. So I will defer back to you all should we choose to do that. But at this point, I think in the the event of not having tons of time today and a huge, robust agenda, I'm going to turn it over to Pat Jones. And Pat and Shule, I have the slides, so just let me know when you'd like me to advance, and I will run from here.
Great. Thank you so much, Michelle, Chair Foster, members of the board, for letting me come again today to provide an update on where we are with the AHEAD model. So you can go to the next slide, Michelle. The first few slides I'm going to go through quite quickly, especially given the time constraints, but I feel like it's important every time we talk about this complex potential model that really sort of level set why we're here, why we're talking about this. So this is actually a Green Mountain Care Board slide. And it, delineates the work for Act 167. The work that we're talking about today is a subsequent all-payer model agreement with the federal government, should that come to fruition. Next slide. So why consider a new federal model and why now? In its most basic sense, as you all know, when we engage in discussions about healthcare reform, we're really trying to use the public policy process to address challenges in our healthcare system. And you all know as well as anybody, based on the work that you do, that we're facing lots of challenges in healthcare. And so I've listed some here with their related goals, but ensuring affordability, improving access not only to care, but also to insurance coverage, optimizing quality and experience of care for Vermonters who seek care, improving the health of the entire population, improving equity, reducing disparities in healthcare and health outcomes, identifying and addressing those social determinants of health that really impact health status. Workforce is a huge issue that we've all been working on together. reducing complexity too in healthcare, and that can arise in part if there's misalignment between public and private payers, and then trying to create a sustainable health system for the future. So, we spent a lot of time talking about payment reform, but really that's just one component of healthcare reform. We should think about as a means to an end. The goal really is for payment changes to encourage and support the care delivery transformation that leads to better outcomes in population health. So just wanted to really level set, why are we even considering this? Next slide. So you've seen this slide before, but one of the reasons why we're considering it now is that our current all-payer model agreement is set to expire at the end of, well, right now we've signed an agreement through 2024, but we are in conversation with CMMI about continuing that model through 2025, but it will not extend after that. What the all-payer model agreement really does for us is it brings Medicare to the table in Vermont's healthcare reform efforts. So it allows Medicare to pay differently for healthcare and establish some statewide accountabilities. And so, we have currently the all-payer ACO model. The original performance period was through 2022. As I said, we have extended through 2024 and are looking to go into 2025 with an extension. But beyond that, CMMI has made it quite clear that single state models like the one that Vermont has, or Maryland, or Pennsylvania, that they want to move to models that more than one state can participate in. Next slide. You've seen this slide as well, so I won't spend too much time on it, but it really outlines some of the benefits of include Medicare in Vermont's healthcare reform efforts. It builds on prior reforms. It gives us, some ability to influence how Medicare reimburses Vermont providers. It provides support for the Blueprint for Health Advanced Primary Care program, and for our SASH program, it gives us some waivers of Medicare regulations that can improve how care is delivered. It's alignment between public and private payers. And that really sends a good signal to our healthcare providers and other health system partners. Next slide. So AHEAD announced, AHEAD is the next iteration of a federal model. It stands for States Advancing All-Payer Health Equity Approaches and Development. It was announced on September 5th by the Center for Medicare and Medicaid Innovation. November 16th, they released a notice of funding opportunity, which invites states to apply for the model. And I just want to emphasize here that really the focus in that, what we call NOFO, is that they really want to see, do states, and states have to be the applicants, do states have the capacity to implement a model like this? And how would states use up to $12 million that CMMI is offering in cooperative agreement funding to support the model? So a lot of the focus on the applications, which for cohorts 1 and 2 are due on March 18th, is in those areas. What is the state capacity and how would we use that funding? There's a link to the website there. I do want to note that, again, that, the application really is the first step. It keeps us in discussion and at the table. States have to be accepted into the model, and then states and CMS have to reach agreement in order to move forward. So think of this application very much as staying at the table on a first step. Next slide. You have also seen this, and it's the AHEAD model at a glance, but just for folks who may not be as familiar with this who are listening in, it really lays out what the AHEAD model entails. First of all, there are accountability targets that states will be responsible for, and that includes total cost of care growth, and that would be for both Medicare, traditional Medicare, or what they call Medicare fee-for-service, and also across all payers. There are targets, and this is novel. This is something we haven't seen before in models, but they're looking for there to be increases in primary care investment. And so again, there are targets for the Medicare fee-for-service population and also for the all-payer population. And then equity and population health outcomes as well that will be determined if states are selected and they execute a state agreement with CMS. And then the components of the model are that cooperative agreement funding that I mentioned before. Hospital global budgets are a really critical element. You're going to hear a lot more from Shule on that topic later. And then a primary care program called Primary Care Ahead. And then CMMI has outlined a number of strategies that you can see that they anticipate will support achievement of the goals of the model. Next slide. I did want to sort of call out those statewide targets and show you how they bucket them. So they really look at the primary care investment targets and the quality and equity targets as addressing overarching goals of improving population health and advancing health equity. And the fee-for-service, total cost of care, and all payer total cost of care growth targets really focus on that area of curbing healthcare cost growth. Next slide. And then the next one. You've seen this slide as well. This is the application and implementation timeline. So for the states that want to be in either cohort 1 or 2, they need to apply by that March 18th date. The difference there is how long of a pre-implementation period they get. Cohort 1 states would have a first performance year of 2026, cohort 2 of 2027. And then the cohort 3 states just get a few more months, about 5 more months to prepare their applications. So their applications are due in August, and they get a 24-month pre-implementation period. So like the cohort 2 states would start in 2027 with a performance year. I should have noted this is limited to 8 states or sub-state regions. CMS only has funding and will only approve up to 8 applications. And there does seem to be quite a lot of interest from states. Not sure which cohorts or when, but there's definitely a lot of interest in this model. And it's a longer time frame, 9 performance years for cohort 1, 8 for cohorts 2 and 3. That's longer than previous models that we've seen, and seems that there's been some learning that taking additional time to implement these complex models is warranted. Next slide. This really outlines the broad timeline for cohort 1 states. So in red, our deadline is March 18th for applications to be provided by states. CMS has indicated that they anticipate that they'll award to states by sometime in May of 2024. And then that implementation period would start in July and go through 2025 for cohort 1 states, with that first performance year of January in 2026. So, just want to put this out here because some of the work, we're really focused right now on that March 18th deadline. There are some flexibilities for states that I'll get into in a moment that really, we have longer time periods to address. So next slide. This is a very busy slide. I'm not going to spend a whole lot of time on this because I can come back to it at a future meeting. But the base slide here is CMS's, and they've laid out what they see as the operational milestones. And this will be once a state has been accepted and decided to move forward with CMS on this model. And so we've put in some, we've added the dates that we understand to be the deadlines for those cohort 1 states. So just wanted you to have a chance to see that again, some of the decisions are well after the application period and would require acceptance into the model and subsequent negotiations. Next slide. And the next. So I am going to highlight sort of a format that I'm using here. The way that I've tried to share this information is that I wanted the board to have a sense of, what is actually required in that application that is due on March 18th. And as I had mentioned earlier, they're really looking to see what's the state's capacity to implement the model. And then in addition, how does the state think about using that cooperative agreement funding of up to $12 million. So I'll go through this slide just to give you a sense of how they're thinking about this. And then on the subsequent slides, I'll skip over the details, but I just wanted you to see what's expected of us for the application. And I want to spend a little time on what we believe are flexibilities in the model should we get accepted. So this section of the draft narrative that we'll need to put together for an application really speaks to that statewide accountability. So again, looking at total cost of care, measurement and growth, primary care investment, and then, some of the levers that we might use for being able to address the statewide accountability requirements. So you can see here that the application is asking us to describe our strategy for measuring statewide total cost of care and measuring primary care investment across payers over time. So they want to see what's our ability to do that on a multi-payer or all-payer basis. And they want to know, what's our baseline? How are we doing currently on those measures? They want us to talk about how we will include targets for total cost of care and primary care investment. And they suggest 3 possible mechanisms for doing that. And, here they're really talking about codifying a process for establishing those targets. So state executive order is one mechanism, statute would be another, and regulation would be another way to codify those all-payer total cost of care, primary care investment targets. They want to know how would we enforce it as well. They want to know how can we obtain the information that we need each year to measure results in those 2 areas from commercial payers and from Medicaid. I'll just give a nod to the board that the all-payer claims database is a nice mechanism to have, even though it has, some limitations. It's a great asset to us when we're responding to this. And then what are some of the policy levers that we might use to increase primary care spending by commercial payers and by Medicaid? And then similarly, what regulatory and policy levers could we use to achieve or enforce total cost of care growth targets across payers? And then finally, what are some of the gaps, if we have them, in how we report on total costs of care and primary care spending? So this is an example. This is one section of the NOFO. That's the kind of information that they're looking for. So next slide. This is where we think there's some flexibility in, for discussion or negotiation with CMS in these statewide accountability areas. And you'll note the deadlines on the right. Again, they go well beyond the application submission. So while we're not focused on this in the application, it's top of mind for if we get accepted into the model. So couple areas. One is that for Medicare fee for service. So again, remember, they're measuring total cost of care, primary care investment, quality and equity targets. They're measuring those both for Medicare fee for service and across all payers for states that are successful in the model. And so a couple of areas where we've gotten indications that there will be some flexibility is that when we calculate total cost of care for the Medicare fee for service population, the selection of baseline years and the weighting of baseline years, because the baseline year is really that the baseline value is that starting point. And they've said they want to see 3 years in there, but which 3 years and how that's weighted, there does appear that there might be a little bit of flexibility. And then they also will build in a savings component. They want to see some savings, or at least not, they've said at least, budget, what they call budget neutrality. And we think there's some flexibility there as well, particularly for low cost states like Vermont, and also states like Vermont that have engaged in prior healthcare reform with CMS for Medicare and have shown savings. So we believe there's some flexibility there. And then calculation of primary care investment. The board, a couple years ago did your report on primary care investment, worked with some other New England states on, methodology there. There's a lot of non-claims payments that are currently occurring in Vermont to primary care. And so one area of flexibility might be how those non-claims payments are handled, because CMS has indicated they want to see them included. And then quality and equity targets, it looks like there'll be some flexibility there to include in a state agreement if we were to move forward with this model. And the state agreement really is that agreement between the state that has been selected and CMS. Other areas where we think there might be a little bit of flexibility, I had mentioned sort of the executive order or statute or regulatory change to set those all payer total cost of care and primary care investment targets. How we set that up and articulate that, we believe there's flexibility there. And the deadline for that is September 30th of 2025. And then the methodologies and targets, actually setting the targets for those measures. Also, we believe that there will be some flexibility, and that does not have to occur until September 30th of 2026. So actually into the first performance year, we could still be setting targets there. Next slide. So I've pretty much laid things out in a similar fashion for the other areas of the application. I'm not going to go through it, but you know, this lays out what does the application require for hospital global payments. I will highlight the fifth row there. We do need, in order for a state to apply, there needs to be at least one non-binding letter of intent from hospitals. CMS is trying, from a hospital. CMS is trying to understand, you know, how is the state engaging with hospitals and health systems about this potential model. And I think, as you know, we've been engaging quite a bit with hospitals and others on this model, and in particular on hospital global payments. I'll also just note that the application will require a detailed hospital recruitment plan as well. They want to see as many providers as possible in this model, and they have a particular interest in safety net providers such as critical access hospitals, federally qualified health centers, and rural health clinics. So they're really focused on how to support care for people that receive their care from safety net providers. Next slide. And then here's some, you know, again, some flexibilities that that we appear to have with this model. The first and the most you know, critical is that states that are like Vermont that have, you know, budget authority, have prior experience with value-based care, they can design as their own state Medicare fee-for-service methodology for hospital global payments. Now, they've outlined some principles, and they need to, you know, there needs to be alignment there. And by the way, CMS will have to approve any state design methodology, but they are willing to provide that, you know, to allow that flexibility and some tailoring for states that have that type of experience. For cohort 1 states, that methodology really would need to be submitted by July 1st of this year. The reason is that it generally takes CMS about 18 months to review and set up their systems to prepare for paying for services differently. So that's why the 18-month, you know, deadline there, 18 months ahead of performance year 1. Couple other areas where we think there's some flexibility. You know, what's the process for reviewing individual hospital requests for adjustments in their global budgets? So for those hospitals that choose to participate, it would particularly pertain to whether there are changes in service lines, either they're providing additional services or not providing services any longer. And the deadline there is May 1st of 2025, so that it can be included in the agreement between the states and CMS. A detailed Medicaid hospital global payment methodology, the requirement here, and part of what makes us multi-payer is that CMS isn't just looking for a Medicare global payment model, they're also looking for Medicaid and eventually commercial as well. And so Medicaid would have to implement a global payment methodology sometime during 2026, and they would have to submit that detailed methodology to CMS by June 30th of 2025. So fair amount of flexibility there. Next slide. this is the primary care ahead. So they ask in the application for a vision for primary care transformation and a plan for how primary care practices will be recruited to participate in primary care ahead. A couple of pluses for Vermont is that a lot of what they're looking for in terms of primary care transformation and payment methods and so forth is we have that in the Blueprint for Health. It really aligns quite nicely with the Blueprint for Health. The thing with primary care is that for primary care practices to take advantage of the opportunity that that Medicare is offering in the AHEAD model, they have to be participating in an advanced primary care model for Medicaid. Some states might not have a Medicaid advanced primary care model. Others, like Vermont, do. And so, and most of our primary care practices, as you know, participate in the Blueprint for Health. And so we're in pretty good shape, it appears, on this particular aspect of the application. Next slide. And so in terms of flexibilities in primary care ahead, I have outlined a couple that appear to be in the model. I couldn't quite tease out the deadlines here, so I assume that it means that this will be worked into the state agreement, which they want to see negotiated by May 1st. Of 2025 for cohort 1 states and then executed by July 1st. So they have said that they'll require 5 measures for primary care practices that want to participate in the AHEAD model. And they've outlined specific measures. However, they have said that if a state wants to propose an alternative measure to align, maybe we're using it in our Medicaid advanced primary care model, that they will consider that, but it has to, they outline some domains and I'll share those with you, but they want to make sure that the measures are, comparable to the measures that they've suggested and that they support the model's goals. So that's one area of potential, albeit limited, flexibility. And then another is that there might be an opportunity under the primary care ahead model, CMS is prepared to offer practices enhanced primary care payments. They're saying that it will average $17 per member per month, no less than $15, no more than 21, but in that range. And they're going to risk adjust based on the population in the practice. And so there seems to be some indication that there might be some flexibility around what tool they use to risk adjust a practice's population. They want to pay more for practices that are serving vulnerable populations. So those are a couple of areas of flexibility in the primary care model. Next slide. Model governance and health equity. The model, we have to outline, do we have existing structures that we could use to help build a model governance structure? How will we identify folks, so forth. And then there's quite a focus in this model on health equity. So they want to know, what is the state currently doing in the area of health equity? And we've got quite a lot going on, including at the health department, and how we can leverage those activities to improve performance. And they want to see some activity focused on identifying health-related social needs, addressing them, reducing health disparities. So they want to see, it's kind of a current state. What are we doing now in these arenas? Next slide. And so there's some, really quite a bit of flexibility. There's some requirements, but they want to, know how we're going to set up a model governance structure within their guidelines. And the deadline there appears to be around November 1st of this year for cohort 1 states. And then one of the key tasks of the model governance group is to establish a statewide health equity plan, and that needs to be done by December 31st of 2025. So just before the first performance year for the cohort 1 states. Next slide. Commercial payer alignment, you may recall that in the model, by the second performance year, there needs to be at least one commercial plan under hospital global budgets. And so this outlines in the application, again, sort of what's current state commercial payer participation in care delivery reform and value-based payment programs and, other sort of readiness activities. And then is there authority to support or facilitate commercial payer participation in the global budgets and, some other requirements there. Next slide. And so for flexibility, again, the timing of commercial payer participation, anytime from model inception, but it must be done by January 1st of 2027. And then there would need to be a hospital global budget methodology for commercial payers. And, there's no firm deadline outlined, but just logically thinking about how long it takes to make the changes, again, the systems, so forth. I put in a date of Q4 2025 at the latest to have a methodology outlined for commercial payers. Next slide. This speaks to health information technology infrastructure. And again, they're really looking to see what's our capacity in terms of data and HIT to support the model and its implementation. Next slide. There's not really, I didn't notice any flexibilities around the HIT. They're really just looking to see how we're doing. So this slide speaks to the cooperative agreement funding. Remember, that's at up to $12 million that they are prepared to give states that are selected. And so, they've outlined intended uses. So recruiting primary care providers and hospitals to participate, the technical work of setting those total cost of care growth and primary care investment targets. They specifically call out building mental health and substance use disorder infrastructure and capacity, and supporting Medicaid and commercial payer alignment across the model. So those are, very broad implementation supports. And within the NOFO, they have asked for a very detailed budget and narrative to accompany that budget. And one of the requirements seems obvious, but that the requested funding must be reasonable. And then in addition, they want to see a sustainability plan, because really this cooperative agreement funding is intended more for one-time or short-term activities. They want to make sure that the work that's underway can be sustained after that funding goes away. The $12 million would be available for the first 5.5 to 6 years of the model, depending on which cohort a state is in. So it's not ongoing throughout the duration of the model. Next slide. This goes into a little more detail about examples of how the funds can be used. So it could be state agency staff, it could be new technology, integration of community services referrals. Because of the focus on health equity, supporting demographic data collection is going to be important to the model. Bolstering HIE, clinical data collection and creating dashboards for providers, supporting population health activities, that's very broad, implementing health-related social needs screening and referrals, and development of both those, the Medicaid hospital global budget, but also commercial hospital global budget methodologies. And then here's the all other, but any other aspects that align with a population health agenda. So these are examples, but you can see sort of their, what they're seeing as priorities. Next slide. I think I've only got 2 more slides. So, I wanted to I know there's some interest in the quality strategy, and while we don't, have to have things locked down for the application, I wanted you to get a sense of what CMS is thinking. So in the NOFO, they talk about, the quality strategy needs to have 3 sets of quality measures, and they all have to have a health equity focus. So there's the statewide measures, that's part of that statewide accountability. Primary care, as I mentioned, there need to be 5 primary care measures for those practices that participate in the model, and then hospital quality programs as well. And CMS has outlined 4 domains, areas of interest for them: prevention and wellness, population health, mental health and substance use disorder, and healthcare quality and utilization. And there's goals, and in a way, they can be seen as examples of the types of measures that they'll be looking for in each of those 4 domains. Next slide. So we, in our discussions and our technical groups and so forth, we've, sort of taken it a little further. There are the federal and state accountability targets. There's a hospital level, there's the primary care. But we also believe that as part of this model, it'll be imperative that there's broader monitoring and evaluation, just to make sure that there aren't unintended consequences, that we're measuring in areas that are of high interest, for example, access to care, care delivery, trends and utilization and so forth. So, we've sort of started that discussion, but that's going to be really important to the model. And then, as always is the case with quality and performance measurement, to the extent that we can have alignment across these areas, across payers, it can really help align incentives for the people who are actually providing the care and doing the work, and it can limit administrative burden. So I think that might be my last slide. Yeah. Thank you for listening. I feel like that was a lot of material. I might have no voice left tonight for the PK meeting, but we'll see. So.
All right, good afternoon. Do we pause for questions for Pat, or should I continue?
Why don't we keep on moving on, Shule, and we can just do questions all together. Unless, Pat, do you need to leave, or do you mind sticking around? What's your preference, Pat?
I'll be happy to stick around. Thank you.
Okay. All right. We'll hold them.
All right. Good afternoon, and you can hear me well, I assume. So thank you for this opportunity, and I also want to thank the state staff, GMCB staff, and the TAG members who really worked with us continuously in the last 12 months or so to get to a place where we are today. So what I will be doing in this presentation is to recap some of the great information Pat shared, focusing on hospital global budget. Next slide, please. And then kind of start building the way that we've been discussing global payment program in Vermont with our stakeholders and thinking through what ahead requirements are and where the state may want to take the global budget payment mechanisms for the ahead application and beyond. As Pat mentioned, ahead has multiple levers and multiple components. There's a lot there, and she did a great job summarizing all of it. And my easy job is really focus on one box here, which is the hospital global budgets, which from the ahead perspective includes only hospital facility payments. So these are Part A and Part B in the Medicare beneficiary structure, and it only includes payments made to the hospitals. It doesn't include any professional services associated with those utilization. Next slide, please. The way that the ahead is setting up the global budget is they are visioning to have separate global payments for each payer type. So CMS is providing an option for the Medicare fee-for-service side to create a state-designated methodology. That means state is going to have flexibilities, but they need to meet certain alignment criteria set forth in the ahead application. Or CMS is going to design and implement a kind of a standard methodology under the Medicare fee-for-service budget. For Medicaid budget, state Medicaid agency is responsible creating the methodology. And again, there are some alignment criteria that CMS is expecting states to meet. And on the commercial payer, including Medicare Advantage, as Pat mentioned, at least one commercial payer must participate, but the requirements for commercial and Medicare Advantage methodology is much higher level, and the states are again in charge of developing the commercial methodology as well. So from this overview, Vermont has two options on the Medicare fee-for-service side. Vermont could design their own version of global payment, or they could sign up to the standard CMS methodology for Medicare fee-for-service. Not every state has this option. Reflecting on Pat's presentation, you know, the list of problems that we are dealing with is kind of similar across the board in the nation. Vermont has very unique challenges, but Vermont also has very unique capabilities that could address and create solutions. And in this case, with the rate setting authority for provider prices, as well as the Green Mountain Care Board and AHS infrastructure, Vermont may qualify for creating its own methodology, and because of the experience the state has, as well as the infrastructure that they have. Another thing to point out is that the ahead is kind of designed with lessons learned from prior state learning. So Vermont, Maryland, and Pennsylvania are mentioned in the NOFO as the example states and the models that the CMS kind of draw lessons from. So we do think that the Vermont has a very strong positioning here. The Medicare requirements, as Pat mentioned, I just want to reiterate, not all hospitals have to be under global payment mechanism. To meet the ahead requirements, it will only include 10% of the overall Medicare fee-for-service spending in first year, and then you would need to increase it up to 30% by year 4. So it's a voluntary program for all payers with the targets that needs to be met by the recruitment efforts from the state side. Next slide, please. So this is another way of looking at the times and deadlines that Pat mentioned. I did notice that Pat is thinking June 30th and I'm thinking July 1st. So if you are detailed oriented, there might be a month difference, but it's only a couple day difference in the way the timeline's set up. The important thing is if Vermont chooses to go with its own methodology, we need to submit the preliminary budget methods by July 2024. That also includes the Medicaid proposals as well. But obviously Medicaid has a longer timeline to get the regulatory approvals. But by January 2025, we need to have the final methodology established, and hospitals would need to sign up to the new payment program by October 2025. And all the programs are scheduled according to the cohort 1 timeline to start in January 2026. Next slide, please. So we do have some time. We don't need to mention much in the NOFO related to methodology details, but after the NOFO, if we were to be picked, then there's really a short period of time to submit that initial proposal for global budgets. So before I get to details, I want to kind of take one step back and think about the global payment model and why states are interested in moving in that direction, why hospitals and payers are interested in this. The ideas behind global payment model is really to move the system from fee-for-service payment model to a fixed revenue model, where in the current model, in Vermont, we do have ACO fixed payments already that are impacting the care delivery. Medicaid has the fixed payments, but commercials are mostly on the fee-for-service side, and the incentives, underlying incentives, are still remaining to be higher payment rates, higher utilizations from the business model perspective. And the focus in service delivery then is if you want to keep the doors open, you have to focus on high margin services, and there might be some contradictory incentives there with the community needs versus what is the high margin services that hospitals have to offer to keep the doors open. And you all are very familiar with this dynamic given your budget review process. Under global payment model, so you could consider that as a tool, and the way you apply it will determine the results. So it could bolster the incentives to change delivery. It could bolster sustainability of the hospital finances. But the idea is that the revenues are set prospectively ahead of time. So the payment amounts are determined prospectively, and those payments are paid through a monthly or some other schedule, so that it is a guaranteed revenue for the hospitals with the policies determined ahead of time. And over time, this revenue is updated with, again, using several adjustments that reflects inflation and membership change, and maybe other changes like service line changes that we're going to get into more detail. So it doesn't mean that it is a constant number over time. It is prospectively calculated, but also it is a guaranteed revenue from the hospital perspective. So they are getting that revenue as a payment amount. Next slide, please. I'm glad I also picked up from Pat's presentation, what is the goal? We should start there and then figure out how to get there. So this is why it's backwards. The first left part is that where we want to go, what are we trying to do in this? And payment system is, again, a vehicle, right? So by itself, it's not the goal to change the payment. What we are trying to do is to improve delivery and really support the transformation in the system. And the transformation here is about lowering the avoidable utilization. So we have the capacity to do better services, right care, right time, at the right place. So that entails shifting the balance in our resources away from kind of creating incentives to reduce avoidable utilization and invest those resources into more population health essential services. So changing that balance in our system from sick care to prevention and wellness care. In the global budget payment mechanism, we bring the financial incentives, so the business model would need to change, but also to accomplish these goals, there needs to be additional support on the transformation side, and AHEAD has some of those components with operational flexibilities that we could get from CMS on the Medicare side, data systems, infrastructure investments, as well as alignment around performance measures to be clear what we're measuring, what we are monitoring, and how those measures are impacting provider payments. Next slide, please. All right. So I mentioned the tag already. The charge of the advisory group was to help us to think through the key components of the global payment methodology, and we met since January, so it's been more than a year, and we are going to have at least one more meeting to kind of do the comparison with AHEAD and what we've been working towards. Again, I would like to thank everyone who participated in the tag, as well as hospitals, payers, and the Office of Healthcare Advocate, who had additional meetings with us to really unpack some of these complicated questions with us. So what I'm going to present in the next couple slides is incorporating their feedback. But as you're going to see, there are still a lot of decisions and questions to be asked and decided. Next slide, please. So there is an alignment in the way that we reach to kind of have to construct the global payments. We will be looking at separate global payments by payer. So here the tag focused on the Medicare side, and this is going to be my focus as well. And Medicaid is working their own global budget payment methodology, and we're working on aligning certain aspects to it. And then for the commercial payers, the vision for the global payment is to create this payment at the payer company level and have adjustments for different markets for their ASO, fully insured, and Medicare Advantage plans. They're all going to come together to create a one single payment from each commercial payer who would be subject to or who will be participating in this model. The considerations here are even though the AHEAD requirements are smaller for a system-wide change, obviously you have to have larger portion of the hospital revenue under a similar methodology. So there is a balance between increasing the participation with incentives and creating that overall transformation that we are seeking under this model. As you can imagine, commercial market is quite dynamic and complicated. So that's another reason why we focused on the CMS first. But we are actively thinking about how we can take some of those methodologies and adapt it to commercial payers as well. Next slide, please. From the hospital revenue streams perspective, we started with the facility payments, and this is aligning with the AHEAD minimum requirements. The facility payments for hospital inpatient, hospital swing beds, and outpatient departments. In terms of the phase 2, as you see here, there is a big interest in including professional services, professionals billing under hospital 10, so owned by hospitals, that goes into the hospital revenue stream. So we bucketed as phase 2, mainly because of the data limitations and additional considerations that we need to make on the professional services side. On the exclusion side, you do see that the patient portion, so the co-insurance co-pays, will be excluded from the global payment. This is the kind of, if you think about the mechanics, the global payment is going to be paid by CMS, and the patients will continue to pay their own share based on their own utilizations. On the other operating revenue, we are not going to be changing the way the other revenues come to the hospital. So these examples are DISH payments, GME payments, and any retail pharmacy that the hospital owns that is outside of the medical benefits that the individuals have. You do see a quick table here just to understand the % of the revenue excluded, and you do see that it is about 13% in 2022, and it's actually declining. So it seemed to me that the more included revenue is going to be, if the trend continues, we don't have an issue about excluded revenues kind of growing disproportionately compared to the included revenues. Next slide, please. From the board's perspective, you have an established process to do budget reviews for each hospital every year. And in this table, we try to explain where the budget review happens and where the global payment is going to come. So the budget review focuses on NPR, net patient revenues, and fixed prospective payments. So that's the overall revenue of the hospital from the patients. As we continue to build our global payment revenues, in this table, the maximum amount that we have is around 70%. So this includes 26% of Medicare fee-for-service revenue that through ahead we could include in the global payment. It does include Medicaid, assuming that Medicaid is going to include all their revenues under global payment. And on the commercial, as you see, it's a potential. We do not expect all commercial payers to participate. At minimum, some of these commercial payers are quite small. Right, so there will be challenges for them to create a global payment and change their practices. So we are still working on what is the potential for commercial payers to participate in a global payment program. So at maximum, the 70% of the net patient revenue may potentially be under global payment model. Next slide. All right, so we covered what is included, what is kind of potentially from the hospital side, what percent revenue, and now we're going to go through how do you construct the global payment over time. The step one is determining baseline revenues. Here, we are going to start with historical payments, and then we'll go through additional adjustments in a minute. Once you have that baseline revenue, we need to think about on an annual basis, what are the factors that we need to take into account to update those baseline revenues. And once they are done, the decisions are how do you pay it during the year? Step 4 is what happens if there is something happening in mid-year, even though we did the prospective calculations. What are the scenarios where there might be a potential update or adjustment to those payments amounts? COVID, we are still kind of aftermath of the COVID impact. You can think about a scenario where utilization really went up. There is a crisis or some sort. Obviously, the fixed payments may not be sufficient temporarily to cover the cost of those additional services, or there would be dips that you may want to think about as well from the payer perspective. And finally, as you finish the first year of implementation, what will be the trend factors that we would like to use for the subsequent years? Here as an example is year 2. So those are the key steps and key decisions that we need to make as we create the global payment model. Next slide, please. All right, so first step is the baseline payments. So again, focusing on Medicare fee-for-service only. For Medicare budgets, this aligns with AHEAD as well, that we are including the amounts from the claims. So this will include Part D payments, which is the retail pharmacy. It will exclude beneficiary copays, and then it will exclude any payments that were made outside of the claims. So these will be the baselines, and we are looking at a 3-year time period. If we start in 2026, you see the baseline years as fiscal years 2022, 2023, and 2024. As Pat mentioned, there is some flexibility in determining the baselines and the weights, but we thought that we would start with the AHEAD as it seemed like an alignment to begin with from the historical revenue perspective. Next slide. In terms of the step 2, as we update the payments, these what we call standard payments are general kind of adjustments across the board for all hospitals participating in the model. There is the inflationary adjustment, beneficiary changes, policy changes, and performance updates. And I'm going to go through them in more detail in a minute. And then we do describe additional adjustments. So if a hospital, so these are more I would say one-on-one adjustments. So not all hospitals may get this. You know, it depends on whether they are making changes to their service lines, whether there are market shifts happening in the market. And then we also kind of discussed hospital-specific payments for tertiary care, for example. The tag and the leads, we worked on creating additional adjustment for tertiary care, and we are working on creating special considerations for safety net hospitals. So you see a lot of acronyms here, but critical access hospitals, safety net hospitals, sole community hospitals, and Medicare dependent hospitals. So depending on their nature of the provider type, there will be specific adjustments to account for different factors that these hospitals face. Next slide, please. So once we do those adjustments, CMS is going to be paying on 26 payments. So they are going to start paying claims and they are going to start writing checks. Hospitals will still submit the claims, so we could do calculations, but at the end of the day, payment is going to be a regular salary for hospitals, if you will, rather than depending on the ups and downs of the claim payments. Next slide. And on the mid-year updates, we propose to have these ad hoc and reserved for very unique circumstances, so that we keep the premise of prospective, sustainable, and predictable revenue. So as you can imagine, mid-year updates could create unpredictability. So we are creating this very limited scenarios and reserving this for major disruptions in financial flows or services or exogenous factors. Next slide. So at the end of the year, it's time to update and calculate the next year's budget payment. Here, learning from the prior experience where the settlements and reconciliations back to fee-for-service creates major barriers in implementation and kind of reduces some of the incentives that we would like to have, we propose no retrospective settlement under global payment. So all the adjustments will be calculated for the next year's global payment, so there won't be any settlement process related to year one, but the year two budget will be updated. Am I going too fast? Should I slow down? Okay. Same sort of adjustments again. So now we're going to look at the future year adjustments for standards as well as the additional adjustments. So everything is updated for 1 year. There will be different numbers, but the methodologies will be the same year over year for updating the global budget payment. Next slide, please. All right. So that's kind of the steps. So again, I'm going to take you one more level detail, and I have a few slides left to kind of now taking a step back and thinking through what are the considerations for each step. So for the historical revenue, validation of the payment amounts and clarifying what is in, what is not in is going to be a key focus for the state, no matter which option the state chooses, whether it's the CMS standard or Vermont. The uniqueness in Vermont is that we need to think about how CMS will continue to pay for Blueprint, CHD, and SASH. So that's going to be an ongoing conversation and potentially something to clarify during the pre-implementation phase. There will be additional adjustments. So if you think about the 3-year baseline, a lot of things may have changed. And if a hospital closed the service or opened the service, we want to make sure that we align the historical revenues. So the starting point for a hospital is kind of reflecting their current service line offerings. Next slide, please. Baseline incentives in the CMS methodology, CMS is offering an upward adjustment of a 1% to fund transformation activities. This incentive is available only in performance year 1 and performance year 2. The goal here is, in addition to provide additional services, you can think about this as an additional incentive to join the program early. If a hospital joins in performance year 3, they are going to be missing out of this additional 1% in the CMS methodology. As we discussed the potential incentives or baseline adjustments with the TAG members, we came up with a few additional considerations for Vermont to think about, given the focus on improving access and also investing in health equity. So we listed them here. There is a consideration to provide additional revenue in the baseline for hospitals serving the most disadvantaged populations. There might be upfront investments needed for targeted areas for access related. And after me, I understand we'll hear a little bit more about that work to understand the needs. There was also a discussion about, as we build this from the historical revenues, and if the hospital continuously have a negative margin, how is the hospital going to change the financial picture of the institution under global budget payment? So there was some consideration about whether we should make additional adjustments as one time to get them to a acceptable level from the start with. And there could be exception-based factors on a case-by-case basis, and CMS methodology actually has that as well. That also opens up maybe unique circumstances that we may need to make adjustments to the baselines as well. Obviously, we could come up with many more, and the important thing here is, do we have how much funding we have to invest in the baseline, and that will be driven by the requirements at the statewide on Medicare savings or Medicare trends. So these are all options. At the end, the final decisions, I suspect, would depend on where the state ends with the CMS ahead savings requirements to go back and figure out what it is that we could invest at the beginning of this model. Next slide, please. In addition to the size, so I think the variation between hospitals, another consideration is how unique this funding is going to be based on the circumstances of each hospital. The 1% transformation incentive is, our understanding, at least currently, is going to be 1% to all hospitals participating, regardless of their situation, I would say. But you may consider, variations between hospitals. Giving more funding for hospitals serving most disadvantaged population is a good example, as opposed to giving a 1% across the board to all hospitals. Another consideration here is, cost efficiency, financial stability. There might be some balances there if the eventual model has the sustainability adjustment, taking into account some of the margins that I mentioned in the earlier options. On the time period side, as I mentioned, CMS's vision is to use this as incentives to join the program early. If the state creates its own model, is it going to be for 2 years, 3 years? And whether there will be payback if the hospital leaves the program in mid-year. So there is an option that any hospital could leave the program, since this is a voluntary program, and CMS does have some clauses if the hospital leaves early that they would have to pay back the transformation plans. Payments, excuse me. And finally, on the accountability side, there is a language in the head that hospitals would need to submit transformation plans. How much you want to tie the baseline incentives to some of those plans or actual changes on the ground is, again, another consideration that we need to work out as we build the methodology together. Next slide, please. One of the requirements of the HED is to make adjustments based on health equity. Global payments will be adjusted based on the social risk of the patients. We do not know what CMS is planning to do in this area, but I'm teeing this up, and it will link with our health equity measure sets as well, that we will be looking at this a little bit more closely in the coming months. And the prior comments from the TAG is that there is a general support in this concept, but the measures and the tools might be very complicated, and we may start with a progression plan. If we have a desired goal, we may not get there in the year one, and it may build up eventually, starting with the measure itself, collecting an additional information, supporting data collection, and move to a payment adjustment in year 3 and 4 as well. Next slide, please. All right, so those are all baseline, how much we could do in the baseline revenue calculations. Now I'm going to briefly touch about the adjustments. I did list the standard adjustments here. I'm not going to go through them in detail, but the idea is that to provide the sufficient updates every year, accounting for changes happening outside of the hospital, as well as paying for performance, right? Paying for outcomes as the last point. Next slide, please. The proposal for inflation adjustment is to use CMS hospital market basket. That is a number that CMS uses for their own hospitals. We do not know what they're going to use for a HED model yet, but our starting point is to use the update factor that they use every year, and it will be kind of projected by the actuaries, and we could use that number as our inflationary adjustment. Here you see the graphic. We all know the increase in inflation in the prior years, 2023 and 2022. You do see that eventually the trend picks up, but there is a risk here that with forecast, we may not pick up everything that may happen during that year. Critical access hospitals and Medicare dependent hospitals may need additional considerations as their cost structures are different, and the average number that is calculated across all the PPS hospitals may not be sufficient for them. Next slide. On the beneficiary adjustments, so we addressed the cost, and now we are thinking about people served. On people served, we do need to make adjustments based on their risk profile. So as you know, as we get older, we spend more on healthcare. So age, gender, and ESRD status for Medicare beneficiaries will be taken into account, and that we will distribute the beneficiary growth to each hospital based on their revenue from each HSA. So we are proposing to do this at the hospital or health service area and calculating the membership change and allocating that membership change after adjustments based on the hospital's revenue from each HSA. Next slide, please. On the policy and performance adjustments, we propose to use CMS policy adjustments, so this should align with AHEAD as well. And AHEAD is also requiring a quality adjustment. We could ask for a waiver not to use the CMS programs, but the initial proposal is to start with CMS and move towards creating an all-payer quality program during the implementation period. There are additional performance adjustments that would be happening under global payment, and those are total cost of care accountability, improvements in health disparities and efficiency, which I'm going to get in a minute. Next slide, please. If Pat gave you a lot of information, I'm giving you even more and more detail. So I'm happy to kind of take questions at the end if you want to get into more detail. But, you know, we talked about the transformation incentives being only 2 years. There is also the opposite, that some of these adjustments are going to start in year 4 or year 5. So I want you guys to focus more on the health equity improvement bonus, on the CMS methodology. It's starting in year 4 as a payment adjustment, and the TCOC performance adjustment is also starting in year 4, and effectiveness adjustment is starting in year 2. So CMS made decisions on when and how these adjustments would start. If Vermont chooses to do their own options, then these are all going to be discussed and decided on the methodology as well. Next slide, please. So on the total cost of care accountability, this is a requirement if the state does their own methodology. And the requirement is that we need to create a methodology if the state does not meet the Medicare fee-for-service state accountability. So if we don't have enough savings, basically, we need to create a methodology where we can link that performance back to the hospital global payment. That's the requirement for the total cost accountability. CMS also indicated that the initial transformation incentives and additional payments for primary care will be excluded from this. Again, in the standard methodology, there is some variation in terms of the timing, but Vermont could also think about which payments will be excluded from the total cost of accountability as we design this methodology in more detail. In addition to the CMS requirements, if we can create an accountability this way, the physicians working with the hospitals could qualify for additional incentives and payments from CMS. And also it is aligning the work with the total cost of care. So not only just putting levers around hospital payments, but linking the payment to a total cost, even though there is a limited impact from the hospital's perspective to non-hospital providers from the beginning. Next slide, please. You know, creating a total cost accountability on hospital is also complicated. One thing to keep in mind here is that CMS is requiring a geographic attribution. So we are not going to attribute patients to hospitals. We have to figure out how we can do and assign certain geographies to each hospital. And there are multiple options here, and we'll be working and looking at CMS methodology to understand what their requirement is to see if we can adapt this to the Vermont methodology. Next slide, please. So finally, on the additional adjustments, you know, the service line is a big one. How do we handle if hospital is changing services? And the hospital-specific adjustments are to a certain extent related, but has their own separate considerations. So I'm going to go quickly on those two. Next slide, please. The service line, you know, we are thinking about 4 scenarios. One is, how do we fund new and expanded services? Because they are no longer going to be paid on the fee-for-service, so we have to prospectively adjust the global payment. What do we do when they close or reduce services? The idea here is that as we are removing the margin question out and incentivizing them to shift services, do we need to take all the payments out from the historical revenue if a hospital is doing the right thing and closing a service that the community doesn't need anymore? The third option is temporary changes. If they hire, you know, if they need to hire a new physician for a retired physician, we know that it's a temporary dip, but we may need to think about how long we want to keep that as budget neutral before we go and make adjustments to global payments. And then finally, to create the incentives and maintain high quality of care, we do want to think about whether we do want to make adjustments if the patients shift from one hospital to the other. And here is the way we are thinking about market shifts is that if a hospital gains or provides more services on the inpatient side, we do want to see declines in another hospital for us to be able to assess and adjust the global payments. So we maintain that overall budget neutrality in the global budget payment program. We did do some development work on the tertiary care services. The goal here is to adjust the global payment based on the changes in high cost services. And this is a unique to Vermont. This didn't come up in the ahead. They do have different concepts. They are trying to do outlier adjustments and exception based. So this could be something we can consider as well. But the way that we have developed this in this STRO model is to come up with a list of services where we create a reconciliation process, so to speak, to adjust the global payments up and down, downward or upward based on the utilization in tertiary care. And this will only apply to UVM and one or two more hospitals, depending on how we define tertiary care. Next slide, please. And finally, we are kind of on the hospital side. We are watching what CMS is going to do for critical access hospitals and Medicare dependent hospitals. They clarified that they do not plan to reconcile critical access hospitals back to the cost report, which is a major change for critical access hospitals and a big issue in Vermont, given the hospitals that you have. We want to understand what CMS is envisioning. They do have some adjustments already to help critical access hospitals on the quality adjustment program, as well as the performance measures. As I said, they sometimes start late or they have only upward adjustment. And they do mention there might be a concept of floor, that the payments will cover certain fixed costs for these hospitals, and that there might be some sufficiency. So those are all undefined terms in the ahead. For expediency and the timing perspective, we are waiting for their definitions to see if we can adapt those and modify them if needed for the Vermont methodology. All right, I have two more and then we are done. So those are all the things that we discussed and worked through in the last 12 months. We did see a few things that didn't come up in our discussions, but worth mentioning here for your consideration. Next slide is the health equity improvement bonus. We did discuss this a little bit, but we didn't really formalize it in the STRO model. But CMS is going to provide a bonus, an upward adjustment, if the hospital perform on certain quality measures that are related to health disparities. So that's the first one. Next one is an effectiveness adjustment. This is a downward adjustment, and CMS is going to be looking at potentially avoidable utilization and reducing the global payments based on the progress made on these measures. Again, it's starting in performance year 2, and the CAUSE are going to start in performance year 3. The measures that they are using is in the next slide. In terms of avoidable utilization, they do not define them yet. They mention them as examples. Readmissions, ambulatory care sensitive inpatient admissions, emergency department visits are what they consider as avoidable utilization. They also mention overuse or low value care measures, and I put some examples here. So all of these measures are driven from claims analyses, and there are specific algorithms developed or vetted by national organizations. And I did provide some detail if you are interested in the appendix for each of these measures. All right. We are ending in the same slide as Pat. At the end, as we develop the methodology, from my perspective, we have a clear link between all three, but more importantly, which measures we want to make payment adjustments, which measures we want to put in the monitoring plan is an important factor to consider. So there might be broader sets for monitoring, and those measures may eventually get to a payment model. But there will be a link and assessment in both of those from the alignment perspective to ensure that we have the incentives balance in the global payments. So, and more to come on those measure sets and the way that we are going to be linking that with the statewide selection of the measures as well. So with that, I think I end it here.
Great. Why don't we take a 6-minute break and come back at 2:40, and then we'll have board members' questions and comments, HCA and public comment. So we'll see you at 2:40. Thank you. Okay, it looks like we have everyone here, so we can resume our hearing. I'll open up to the board members for any questions or comments that they may have for Shule or Pat.
I can jump in if you want, Chair Foster.
Sure, great. Thanks.
Okay. Well, first of all, thank you so much. There's so much to digest here, and I know there's a lot of hard work and stakeholder engagement and modeling efforts that have gone on behind the scenes for a year plus to get us to this point, and I really appreciate that. And want to say I think this is an intriguing model that I'm really glad is under serious consideration. I think there's a lot to like about it. I think most of my questions may be more directed to you, Pat, and are probably closer to the top of the decision tree. In terms of, I think of the decision tree ahead or no ahead, and then if ahead, what does the global budget look like under there? What does the model look like under there that's going to be best for Vermonters? So I think today a little bit as I'm just trying to get a sense of the analysis that we need to do to make sure that ahead is best for Vermont compared to the next best alternative. So really trying to understand what happens if we don't do ahead? What does that look like? What fee-for-service version are we in? And then how do we compare the two worlds on a couple of different dimensions? And I just want to preface by saying, I know that the NOFO app is just a preliminary kind of non-binding step, which I totally agree we should submit. And, you know, I'm grateful that we are submitting it because it allows us to have this conversation with the federal government. I'm just more thinking about what are the types of analysis that I think would be helpful to see before the state signs any final agreement, or perhaps as we go into negotiations around what that agreement looks like. So most of my questions, like I said, are a little bit more 40,000 foot today than, you know, 5,000 feet about the intricacies of the global budget model, which I think I will have questions, and I like a lot of what I see there. So one of the, I think I'm going to back up a bit. And when I think about the challenges that our health system faces right now, and I think about, you know, obviously affordability of healthcare. I think about it for the uninsured, the underinsured, the employers, the school districts. Everybody is trying to pay premiums right now. I think of really long wait times for specialty care. I think of insufficient access to primary care. I think of patients boarding in the ED because there's no mental health beds, or inpatients ready for discharge, but there's nowhere for them to go because there's not enough SNF beds. These are the things that I think are acute challenges that we face. And so when I start to think about the ahead model, I imagine how will this model impact those very, very specific issues relative to that next best alternative of probably some fee for service. So one of the questions I guess I have for you, Pat, is this model is certainly designed to curb healthcare costs, specifically for Medicare and Medicaid. And it looks, you know, has promised to do that. I'm interested in thinking about, you know, the balloon analogy that sometimes I give, right? If you squeeze on one end, does it pop out the other end? And so I'm wondering, are there plans to try and model what's likely to happen to commercial insurance premiums under ahead versus under that next best alternative? But I guess that's my first question. Then I've got a couple others related to that, but.
Great. Thank you, Dr. Holmes. There's a lot, there's actually several questions embedded in there, I think. And so I'll try and you know, address each of them. You know, the first is, you know, what happens if we don't do ahead? And I really do, you know, we get asked that question a lot. That's why I started out the presentation with the why are we thinking about this and why now? As you know, our current model will not exist beyond 2025. CMS has made that very clear to all states that they're not going to do these single state models anymore. And so it's not like we can stay in the status quo. If we don't do ahead, we're really looking at fee for service for Medicare, at least. And, you know, I think a lot of folks with, you know, with sort of the incentives that are baked into a fee for service model, you know, I think folks would see that as a step backwards. We've done a lot of work to really position ourselves to continue to advance alternative payment models. Maybe we, could do Medicare fee for service, but that leads to that type of fragmentation across payers that I think we've all worked hard to try and avoid as well. And if we don't participate, I think, you all know I've been at this for a long time.
And we thank you for that. We know how much work you've done. So
well,
yeah.
And I mean, I feel like you said, I see some opportunity here that I have not seen in prior models that have been offered by the federal government. It's not perfect. There's some things that are missing, but I want to start with the investment in primary care. This is, if we're looking at ways to address costs, and now I'm, I think really going to get to your question about what does this mean for costs overall? What does this mean for commercial payer costs? There is, I just spent a couple days, Michelle and I did, talking to other states in Washington about primary care investment and sort of the evidence around that and why it's so important to continue to focus on improving investment in primary care. It's better for patients. It's better it's better for the system. And so to see a model that actually says the state is going to be accountable for not only Medicare fee-for-service primary care investment, but also all payer primary care investment, to see a model that, actually makes a strong effort to increase payments through those advanced primary care payments for primary care practices that participate. To see a model that focuses the way that this one does on safety net providers, critical access hospitals, federally qualified health centers, rural health clinics, and that focuses on health equity. And how can we reduce disparities in health? How can we make sure everyone is getting the care that they need and deserve? Those are some pretty encouraging aspects of this model that do potentially have impacts on outcomes and costs. And so sort of the more comprehensive nature here that we're seeing is encouraging. I think you've all probably heard me say that, one area where where CMS is expressing interest, but they are not, there's nothing overt in the model, but they're definitely saying they want to see that balance from hospital care. Let's invest more in community care and post-acute care. The very things that you're concerned about are bottlenecks in the system. There's definitely a desire to do that. And so I think we have some opportunity, even if it's not really over there. There is a fair amount to lose if we aren't able, for any of a variety of reasons, to move forward with AHEAD. It includes that, Medicare obviously wouldn't be in our health, in our healthcare reform, so that, we would not have Medicare at the table. As you know, almost $10 million comes from Medicare to support the Blueprint and SASH programs. And if there's not continuity in the models, that's going to go away. The $12 million in cooperative agreement funding, it's not a ton of money. It might not be enough, but it's something to help Vermont continue to advance toward better health care for Vermonters. The per member per month, those enhanced payments for primary care would not be available. And, you know, there's, again, that opportunity to really focus on equity. All of those things together. This is not a one solution
Yeah,
dilemma.
no, I know that. I'm just trying to, it's helpful to think through and quantify what it's going to look like in a world where we don't do this, right? So the but-for
Yeah.
world, what does that look like? And I think about, you know, you've raised some other important dollars coming into the state. I think it would be helpful to model the difference that we expect in federal dollars coming in under each scenario for the duration of the model, right? So there's federal dollars that are coming in ahead. There would be federal dollars coming in if we were in fee for service as well. I mean, you know, there's dollars coming into the state, and there's expectations on total cost of care reductions, you know, that are going to impact those federal dollars coming into the state. There's dollars coming in for Blueprint and other, you know, really important programs, but there's also costs associated with being in the program in terms of the regulatory costs and the compliance costs and the quality reporting costs and all. So I guess, and I'm only asking this because I think it's really important to understand what does it look like in the world where we're going to go forward with this, and what does it look like if we didn't, and what is the delta on the federal dollars that we can expect over the duration of the model. And quantifying that, you know, and really trying to isolate the dollars that are coming in for healthcare services under each payment model, netting out dollars coming in that are tied to doing the model, right? Do you know what I'm saying? So I'm trying to understand that, and I think that's a really, I think that would be helpful for us to see. For example, if we go ahead with it, you know, one of the rationales is potentially there's all this different targeted dollars to help us achieve our equity goals and our other types of goals. But I haven't seen that number yet, and I'm trying to figure out how do we get our hands on that.
Yeah, we don't have the CMS methodology yet for hospital global budgets. And you know, frankly, you know, because there's actually a lot of flexibility in a state design methodology, that'll be part of our, if we were to be selected. And I want to keep emphasizing that there are other states. I just heard of another one today that's applying. I mean, there are plenty of other states that are interested in this, but you know, it's a competitive process. If we're selected, part of the negotiation will be around, you know, how do we you know, make adjustments in the hospital global budget methodology, and then we'll have a better sense of that number. And we should look at that and model that as to what it means for the state. You know, it's a little hard to tell with fee for service because it really depends on volume of services. You can project what would happen if we were to revert back to a fee for service model. We could do some projections. So there, you know, I'm not going to overpromise. There would be some estimates and some assumptions that would have to be made in doing that type of analysis. So we're anxiously awaiting the methodology. Then we would look at that and try to do some modeling based on what we're seeing. But the real modeling is around what we negotiate if we are selected in terms of the Vermont specific methodology, if that's the option we decide to pursue.
Right. And that makes all the sense in the world. You know, I can appreciate a lot of the stuff has to be done after we understand the CMS methodology and after we've, you know, designed these straw models and tested them and kicked the tires around a little bit on what the adjustments can be and what latitudes we have to draw down more federal dollars in those adjustments. And I think that will all, I recognize that will all take place in the negotiation process. I just think that if we have a strong understanding of all of this going in, we might be able to bargain for more. I recognize too that there may be other states that are competing with us and we may not have as much bargaining power, but you know, let's try and leverage all that we can to try and shore up some of the challenges in our state as we see them now, some of these really acute challenges. What are the ways that we can address those through this model and through drawing down some federal dollars? And I guess I only have two other questions, I think. One is, I think you've heard me talk a little bit before about access, and that's really something that I'm deeply concerned about. And I think about our model now, which is, a fee-for-service model where the incentive is to drive volume. And we still have major access challenges in a model that's incentivized to bring as many patients through the door as is possible. And so I think about how we model or reflect on a shift towards a global payment model and thinking about how we're going to, what we expect to happen with access and wait times and provider productivity. How do those incentives change for provider productivity, patient throughput? Like how do we think about that? How do we mitigate against access challenges that may ensue? And one of the things I think about is before we embark on this model, we have to have a pretty good idea of the baseline access challenges we have now, the wait times, and we don't have a very good system in place right now to be monitoring wait times, frankly. We do the best that we can through the hospital budget process, but it's not ideal in really understanding the patient experience and accessing specialty care or even primary care. And so part of what I think about is if we're going to go down this path, I think we need to be investing right now in developing a baseline understanding of what the access challenges are now so that we have a mechanism going forward to be monitoring any changes that we're seeing as a result of changes in the payment model. So I just want to put a plug in. I don't think we can wait until 2026 to start thinking about how do we monitor access, because we need a really good baseline from which to move from or to understand any movements from. So I guess it's not really a question. It's just a concern I think I have. And maybe it's, maybe it's not going to be a concern that we need to address, but I'd like to think about it now rather than waiting. I guess my last question, Pat, for you is a little bit of, there's the 3 cohorts, and I think about the timing a little bit of our entry into this potential model, if it works out and we're selected and the negotiations work right. And I wanted to ask a little bit about optimal entry time. I think I asked this a little bit last time, but I've thought a little bit more about it since our last meeting. And on the one hand, I can see why early entry might be better, because our all-payer model agreement is ending, and there's, what do we do in this interim period? And we don't want to lose the momentum that we've had on this. But the other flip side of that is I think about this community engagement process that we're involved in now. And that process is going to lead to recommendations for delivery system reform, ways to improve efficiencies, reduce some of these bottlenecks, maybe create centers of excellence, think differently about how we deliver healthcare. And I'm just wondering the timing of making those changes, and then on top of that, trying to layer on a payment system. So just wanted to ask your thoughts a little bit on, there's so much happening simultaneously. There's the sunsetting of the all-payer model, but there's also this really exciting opportunities to think differently about how we deliver healthcare, and how do we fit it all in a way that makes sense, if that's a reasonable question for me.
Yeah, and I do want to just say, agree with you on the access points that you made and the need to have a baseline. And that should be part of our monitoring process. I think the concerns we've already articulated around the discontinuity, we would definitely lose the Blueprint SASH funding. For SASH, as you know, that's like the whole model, pretty much, at least operating costs. There's a potential. Well, I'm not. There may be a potential to get, in that flexibility to get some
a little Band-Aid or something that was.
Yeah. I'm trying not. I think we're venturing into negotiation territory, so I think I better just leave it at that. But there's some concerns with discontinuity in terms of the transformation work that you all are engaging in. I don't see that as a deterrent because those things, whatever the recommendations are and whatever uptake there is of those recommendations, it's going to take some time to implement, and that can only help us down the road if they are transformation activities that actually result in better outcomes and lower costs for folks. So that doesn't seem a deterrent to me, although, I hear what you're saying about the complexity of everything happening at once. But this is a complex environment. And I do worry a little about saying, okay, you're all in, an all-payer model now, that's going to go away, go back to fee for service, then go to, if we want to, say we're to, want to try for 2027. I'm not sure it would be worth it because it would be, in other states where they're in fee for service and they don't have the kind of model we have, it's one transition. Here we'd be asking people to make two complicated transitions. And, so I think that's a concern when you look at the what we might have to lose. Because really, like from an application standpoint, would I love 5 more months to develop an application? Why, yes, I would. But,
Yeah.
but,
That might let you sleep
it's
for the next
only
couple of
5 months. And then
Right.
it's a year difference on the implementation, which that's more significant, but it's not endless. And what CMMI has said is that they're going to award no more than 5 states for cohorts 1 and 2. Now 2 has the later start date too. But they're going to award no more than 5. So that would leave like 3 slots for cohort 3 or more if they don't award a total of 5. So they're going to keep at least 3 for cohort 3. So, and if it's daunting, it's unbelievably complicated. I mean, the presentation we just heard, it's but Vermont is probably as well positioned as any state to tackle this, and it's still complicated and daunting. And we've engaged in complex change before, and it's a different landscape, but it is an opportunity. It seems to me.
Right. I think, no, it definitely is an opportunity. I'm glad we're exploring it. And I think you said something very accurate before. We are very well poised to do this, given the reform efforts that we've done so far, which tells me that we probably have a lot of leverage. But that's,
Maybe.
this is my last question is actually for Shule, and then I'm pass the baton. And this is a little bit more about the details. This is my only question about the details today, because I've really got to absorb a lot of this, modeling here. But I think one of the key lessons we learned from the all-payer model is that having a foot in 2 canoes is really just doesn't work, right? And we know that expression. It's been completely overused, but the idea that, you got to get enough of your patients in a particular payment model. This is the point of alignment that we're trying to achieve here. And I believe that sincerely. So when I look at this, the model requires only 1 commercial payer, and only by year 4, 30% of Medicare fee for service, needs to be in a global budget by year 4. So I'm just wondering, Shirley, this is more for, I think maybe for you, although Pat, you have such expertise in this as well. I'm wondering, is that enough revenue to incent the reallocation of resources and the delivery of system reform that we want? And is there a minimum floor with which we should say this model is only going to work if X% of the revenue is in fee for service, which means that we have to get a certain number of commercial payers in, and we have to get a certain, proportion of the public payer revenue in before we can really say that this is going to have a chance at success. So is there a number in mind? Is there thoughts on this? How do we think about that?
Well, I think that's a great question, and probably we need to ask that to the hospitals from their perspective. But from my perspective, I was trying to explain for the commercial side, given the number of plans and companies in the commercial one, if a commercial payer has very few residents in Vermont, like how are we going to think about it? We scratched the surface on the commercial participation, but we, end up working really hard on the Medicare side. I think we need to come back to it. The other piece is, it takes time to do those things too, right? So it may still be reasonable to start with, substantial public participation and gradually build on the commercial one. I don't really have a good sense the pros and cons of doing that. So, those are kind of initial thinking, but really, I think you're right. Like for a model like this to work, we are asking for major transformation. That means majority of the revenue should be under this and align. So that's given, but what that number looks like would probably depend on each hospital's kind of services and the commercial market that they have. Pat, I don't know if you want to add anything else to it.
No, I don't think so. Clearly having, a hospital having the two public payers, and in Vermont, that's a pretty good chunk of their revenue, and is in fact likely for most hospitals to, be the majority of the revenue, especially given, Medicare utilization. But I agree with Shule that, we have focused on Medicare, but we would want to, if we were to move forward very quickly, dig in with the commercial methodology as well and see what, gauge the interest. We've had some conversations with our commercial payers, and they're part of our technical advisory groups. And, so it's, they're at the table. But, there's a lot, we'd have to essentially do the same kind of work for them.
Right.
There's
And I know it's a lot of
similar
hard work.
and similar flexibility. We have similar flexibilities there as well. So in fact, maybe even more so than with the Medicare model.
Awesome. Thank you so much. It's always great to hear from all of you, and thank you for answering my questions. Appreciate it.
I have a couple because I'll just go because they kind of relate to some of Jess's. I guess in our hospital budget process, we heard a lot from hospitals about how the Medicare amounts weren't sufficient for their financial needs. And if the public payers are being capped at this market basket level, how is that going to be enough for our hospitals? Because historically they've needed to, look to the commercial payers for more money. And that's sort of been a big part of their presentations. So if we cap Medicare, how would that be enough money?
So I'll start, and Shule, please feel free to jump in as well. But I think, again, one of the benefits of a global budget is that it provides significant flexibility in how care is delivered, and it provides that predictability in revenue. And if care can be delivered in a different way, and if we could do some of that rebalancing of the system so that primary care is enhanced and less hospital care is needed, then there is some potential for not only we'd want to make sure that the revenues coming in through the global budget were set at a sufficient level, allowed for aging of the population and so forth. But by the same token, if we can accomplish some of these changes in care delivery, it could also, help us spend those Medicare dollars differently so that people were, whether it's telehealth or whether it's, more primary care. There seem to be some areas where we could have less utilization and better outcomes for our Vermonters. So I think there's some potential, but a lot of it's around that baseline too, and the adjustments that get made, and how we can ensure that there's sufficient revenue to start, that the trends are sufficient, and that the adjustments that we make are ones that make sense for our state. Shule, would you add anything to that?
Yes, I think the other piece, I think you touched it on, Pat, but the avoidable utilization is the highest among the Medicare population. So if you think about effective interventions, let's say ED visits or inpatient, if you have a diabetic clinic that is supported and can handle more than what they currently have, it's going to draw down inpatient utilization at the hospital. But hospital is going to keep that payment from their historical level, but they are not going to have the cost of providing that services for that utilization, right? They're going to save from supplies, they could utilize their nursing staff for other purposes. So that's the rebalancing Pat is talking, even though on a unit level,
as soon as I can. Thank you.
Medicare
At the
may
tone,
not
please
cover.
record your message. When you've finished recording, you may
That's
hang.
not me. So at the unit level, even if Medicare may not be paying full cost on the utilization side on their fixed revenue model, there will be potential savings for hospitals to reinvest.
Okay. So our hospitals are pretty unique in how they're where they're placed and sort of their circumstances, right? Like the rural nature of the state is really creates different opportunities and challenges for our hospitals. How does this model address the rural nature of our state and our hospital structure?
So I think you saw in one of the tables that Shule showed that the CMS has given a lot of consideration about how to get safety net hospitals and primary care providers into the model. And so, I'll just give some examples. For quality measures for critical access hospitals, that's an upside only construct for them. They will get additional payments for quality. They will not get downward adjustments. There is risk adjustment that would occur for both the hospital, global budgets, and for primary care enhanced payments that are based on, risk factors. And so practices and hospitals that serve more vulnerable populations would receive additional funding to try and meet their needs. There's the, transformation dollars that we've talked about that would help support that work as well. I was thinking about when we were talking about geographic attribution, I was, when Shule was talking about that, I was actually thinking about what that would look like in a state where there's multiple hospitals in a service area, and it seems like it could be more complex in that kind of an environment. Whereas in our rural communities, hospitals know who their communities are and know who they're serving. There's no question that the move away from cost-based reimbursement is challenging for our critical access hospitals to think about. And so that's an area that I think we want to keep discussing and exploring. But the model does seem to be, designed to really try and bring some of those smaller hospitals and smaller providers into participation. And there's a few different incentives that should help in that regard.
And
Um,
one addition, sorry, Owen, one more thing. In terms of social risk, they focused on area deprivation indexes, but Vermont could propose rurality as a factor. So to me, that could bring additional resources to our rural providers if we incorporate that into all the adjustments that we talked about.
Is there any risk? So there's service line adjustments. If you add a service line, you get an adjustment. And I guess one question I had is whether or not that could potentially favor larger hospitals vis-a-vis smaller hospitals, because potentially they want more revenue, and so they might try and recruit service lines from other hospitals. Is there any risk of that? And the problem with that could be that then the distribution of resources in the state gets consolidated.
Shule, do you want to take that one?
Sure. I think the risk is in the fee-for-service too, right? Right now, the same dynamics are occurring. So we need to think about how global payment is going to change that a little bit. And to me, that may create additional processes for states to think through the policy. So we talked about access relate as we are defining what adjustments will be made for new services. I will give you an example from other models where there is a list of essential services, and maybe Act 167 work that we're going to hear may give us a little bit more what we mean by transformation and what those new services are. There might be adjustments upfront for those services. And for others, if it is about market shift, that could be done at the end of the year to create that barrier in a way to avoid some of that consolidation issues, like because they have to bring the patients to them as opposed to upfront funding for access related services where hospital needs investment and new resources, and they are they don't need to bring the patients from another provider, if that makes sense. So there might be different ways of thinking about new service lines in the way you put the methodology together.
And then, I mean, if it were not in the first cohort, Vermont was in the second or later, I mean, would we actually be going back to fee for service? Because to me, I think someone said something about we're asking them to make two transitions, but to me, it looks like they'll very much be in fee for service anyway, right? Like part of this is going to be in fee for service, part of it's not. If there's one insurer, if there's no professional services included, depending on how many hospitals. So they're going to be in two systems regardless of when they join. Or am I misunderstanding that?
Well, certainly yes, some hospitals get fee for service now, but this would mean that Medicare would go back to fee for service. And that and the payments, the mechanics of the payments would be fee for service.
And then I think the last one, although I have many others, but one is, we have the 167 work that we're going to hear about in the transformation. This is going to what Member Holmes asked. There's going to be a report and some recommendations and opportunities of ways to streamline services, add services, reduce services, expand services, whatever there may be. If I'm a hospital going into a new process with a global budget, I feel like I would be disincentivized to want to make those changes before I get my global budget. See that differently?
So
I do. Sorry,
Go
Pat,
ahead.
can I jump
No,
in?
you
I mean,
go.
we don't know the
Yeah.
recommendations, but to me, if we can link those two streams nicely, if you get a prospective payment, if I'm going to close a service as a hospital, I may not need to worry about losing the revenue from those services from the get-go, right? Because under fee for service, if I shut down, I lose everything right at that point. And if I'm opening a new service, for me to earn that new service, I need to bring the new patients. So it's going to take time again for me to build up that revenue base for those new services. So I think, without knowing too much detail on the Act 167. To me, there might be a nice alignment if we can figure out how to do it. It is complicated, but to me, I think that might be an opportunity for us to really create a dynamic where the transformation, like finance, doesn't become a barrier for transformation.
Yeah, I was actually thinking along the same lines that, you know, that a global budget actually provides a bit of a glide path for those transitions. And, you know, chances are if a new service is being stood up based on recommendations that come out, I think you're getting recommendations in the spring. You know, the timing is actually probably somewhat aligned there.
And then a question I've just heard others ask is why start at baseline? Are we considering the proper allocation on a statewide basis if we start at baseline? So for example, there's like two different levels of that. There's one statewide distribution of resources, right? So do we want this much money of our healthcare dollars in the hospital system? Or two, within the hospitals themselves, the 14, is this the right allocation for what they need today on day one? And then third level, even within those hospitals, is that how they should ideally for their community be dividing up and using their money with the services that they have? So really 3 levels. And I guess the question is really what's the pro of starting at the current baseline and how does that consider the necessary cost to operating for their operating expenses?
Yeah, I mean, I think, you know, we obviously have some years of historical revenues that this board has influenced based on the information that you've gathered. And so, you know, I mean, first of all, see, that's what CMS has put forth, but I think there's some sense to it because it could be a major, you know, it would be a major shock to reallocate when you've got years of historic baseline revenues in a fairly highly regulated system. So.
I don't have any other questions. I think this is really exciting, and I think there's a lot of work to do in the negotiations and a lot to learn. So thank you for keeping us informed and all the work that went into it.
Thank you.
I'll try to jump in with some questions here if I can. I don't know. I'm unusual setup in an unusual location for myself, so I hope you can all hear me just fine. So first of all, you know, thank you so much for all the hard work for the last better part of the year, trying to understand this system, digest it, and optimize it for Vermont. I guess the first question I want to just bring up is on Medicare fee-for-service. I always feel like this is a kind of a complicated, nuanced discussion because while we talk about reverting back to fee-for-service, but in many regards, but not all, I think, we're in fee-for-service now. So at least it's reconciled back to fee-for-service, if I'm not mistaken. Is that's correct, right?
On the Medicare side, yes.
Okay, so it's not that we would go back to fee-for-service. We're in fee-for-service, but we would have different reporting requirements and the payments would flow differently than our current situation. Not that we would revert back to something that we're not in. Like, is that fair to say? Like, there's definitely an all-payer model has allowed us to have different reporting requirements in the state, but it's not that we'd revert back to something that's completely different than what we are doing now.
You know, the model now has given hospitals and others who have taken prospective payments, because the payments are prospective. They haven't, you know, been able to count on the, you know, non-reconciliation, but, you know, they've been able to work together under an ACO organization to learn about what prospective payments look like, to, you know, share in some savings. And they've, been able to do it on a multi-payer basis. And, during the pandemic, we certainly saw what a difference those predictable, reliable payments made. And there were still some incentives in place to provide appropriate levels of care. Going back to a total fee-for-service basis with no, no prospective payment construct, it is volume driven. It's, people believe that it's part of the reason that we're in this situation, not the whole reason, but part of the reason why we're in the situation we're in now, where we've, over the years, maybe not so much in Vermont as in other places, but we've seen costs escalate because, in order to get paid, you have to see someone. In order to maximize revenues, you need to increase volume. And, that would be the incentive under a fee-for-service program. And it's not a model that folks believe has served the healthcare system well from a cost point of view, or maybe even from other points of view as well. So, I mean, it definitely would be a change for our providers in terms of how they're getting payments and what the incentives are.
And I
Yeah,
think,
go
Dave,
ahead.
before you go in, I believe in the current system, there is the shared savings component, even though it is reconciled back to fee-for-service, there is that target and shared risk through the ACO. The way that I see a change is, the current model, it's focused on individuals, right? Attribution, and we weren't able to achieve the scale target with all the complicated primary care out of state, et cetera. But this model is focusing on institutions and hospitals, like all hospital revenue under Medicare will be under global payment, regardless of where those patients live. So that's changing the dynamics to an institution as opposed to a patient to capture the full revenue. Going back to fee-for-service kind of puts, again, back to the same thing about, okay, then it is about, trying to attract and do more of the things that are profitable. And if you are thinking about primary care as a focus point, linking primary care with the hospital is an important dynamic too, because at the end, hospital is going to move in this direction, but primary care is going to move in the other direction, right? So that's another reason why moving back to fee-for-service may create long-term issues for the system, because then there is not an alignment in the objectives from the provider perspective.
One way that I think about global budgets being different than the current system, and I don't know if this is, I haven't really talked about this, I've just thought about it, is that in the all-payer model, that shared savings is through the system, and I feel like the incentive on a local level to achieve shared savings is low, because, well, if you do really good work to achieve shared savings, you generate less fee-for-service Medicare revenue, but that maybe the whole system doesn't generate shared savings, you don't get a payment back. In the global budget, if you generate shared savings in your local area, you would keep shared savings to your hospital. So that's one of the kind of the benefits that I think I see with the global budget methodology over the all payer model methodology. I do think this kind of gets to some of my other questions, which is when we talk about utilization within global budgets, though, Vermont has this remarkably low inpatient utilization rate for especially Medicare beneficiaries, but all people, all Vermonters per capita. We have relatively high ED utilization, and so trying to figure out how, from looking at the data, especially from your standpoint, Shule, I think you've delved pretty deeply into the data that's available for Vermont. Where are hospitals going to be able to to move that? Are hospitals going to be able to reduce inpatient utilization further, and what would be needed? And how are hospitals going to be able to reduce ED utilization from its current standpoint? And then are there specific areas that we've identified that we can move that needle on?
I'll take it. Yes, there are lower utilization, but when you look at it, 20 to 30%, depending on which hospital you are, is from chronic conditions. And from the patient perspective, it is better if we can find the right care before they end up at the hospital, right? It's a tough thing to do, but probably the right North Star that we should aim. Again, on the ED as well, there might be some low-hanging fruit, but a lot of it is going to require coordination and long-term investments to be able to shift those services. If you were to give this the higher, like at a higher level, hospitals and our systems were designed with acute illnesses, right? We haven't had major shifts in the way we delivered the care. Maybe, in the last 5 years, we did some, but at the end, I think we need to be bold and think about what is the ailing illnesses, our population, and what kind of care they need, and try to move in that direction, even though it is going to be a hard thing to do.
So to reduce those chronic condition hospitalizations, especially in Medicare patients, I would assume we would need better primary care resources, specialty care resources, home care resources, long-term care resources, and post-acute care to resources. So I guess I'm trying to figure out, does shifting to the AHEAD model help any of those things directly, or is it, are we sort of trying to build in there an incentive for hospitals to advocate for those things to be improved?
I would say that the hospitals are strongly advocating on those issues as it is, particularly around the post-acute care, and not just the hospitals, home health agencies, the skilled nursing facilities. And I think, as you know, part of our work together has well over a year has been to really focus in on how we can support those systems in being available so that people aren't boarding in emergency rooms or staying in hospitals longer than they need to. There's still a lot of work to do. It's this is another one of the all hands on deck type of efforts that we need to make together, but we have made some progress. AHS did some work around the Brattleboro retreat, and that seems to have helped with some improvements. There's certainly discussions going on around how we can, look at reimbursement for skilled nursing facilities. We did some rate studies around home health, adult day, other areas of the system. And, the legislature, that resulted in some increases last year. And so that's work that we'll continue to do regardless, but it's definitely going to take a concerted effort. Workforce is another area. I think, as you know, we've been really working hard to shore up workforce as well, and have a number of programs that are in place to try and do that. But it's going to take a persistent and concerted effort from multiple facets to deal with these issues that are present not only in Vermont but across the country, frankly. And there are some opportunities there. I mean, those are opportunities. It's but we can't let up in our efforts there. So.
Agreed. Strongly agreed. This is one, I guess, mainly for Shule, with your work in other states, and having seen gold budgets be implemented, and the idea that the cost savings which which is really the hospital sustainability, community healthcare system sustainability benefits that come out of global budgets, are really penned to the idea of improving prevention services up front and reducing costs. Those are slow and long and hard things to do. What do you think is a realistic timeline for us in Vermont, if we were to implement global budgets in 2025, to see those be the real reasons where we're saving money within the system and improving care?
I'm getting all the difficult questions. So the timeline, I can't really tell, Dave, but I'll give you examples where there could be some short-term savings opportunities, right? So in Maryland, one hospital invited dentists to come. They looked at their ED utilization. They realized it was dental issues that they were dealing with. They worked with the local dentist and opened like a day, and dentists came and provided services to the community. So that's the short-term way for improving access, but also reducing utilization at the hospital. Long-term, you have to figure out where, how you're going to get that dentist 24/7 or right. So, but there are some places where, given the right incentive and support for data and understanding the community, there might be things that we could do short-term. Obesity, diabetes, hypertension, these are big public health problems that require large investments in long term. Another example on the nursing home side, one other hospital created a partnership with the local nursing home. They send their hospitalist to that nursing home, 1 or 2 days to take care of some of the patients that will be transferred to the hospital, right? So 3-day rule, like there's regulatory flexibilities that they receive, but also kind of work with the nursing home to create some additional resources for that nursing home to solve, again, the short-term problems. So, and these build up to a long-term solutions, right? So in terms of the cost savings, Pennsylvania implemented rural health model. Their focus was on hospital sustainability, not so much on the cost savings. So we also need to think about our goals. What is it that Vermont is doing? And given what you mentioned on the Medicare side, if the transformation is the goal, short-term with the baseline incentives, the trend will go up from the historical, right? So we need to be realistic about the upfront investments needed for the long term. And, AHEAD has a 9-year implementation. So depending on the negotiations, it's the 9-year glide path. So that's another consideration to have. So I don't have an answer to you.
The way I take what you said with the 9-year glide path is that, say, for instance, that within AHEAD that the glide path could be designed such that there's more upfront investment in the 9 years.
Yeah, and I think we should take
Medicare?
that to the executive session since it's getting into the negotiation. But AHEAD has exclusions from the total savings. That's right. They are going to exclude primary care. They're going to exclude transformation funding from the savings requirements. And then it is a 9-year program. So at the end of the day, the guardrails of performance in 1 year doesn't necessarily kill the program, right? So that's the other consideration in terms of what is the trajectory of savings requirements and how state can negotiate with the federal government.
Yeah, I think when I look at when this is presented to me today, I feel I'm looking at more as, is this the right decision for Vermont, as opposed to, can we comply with what CMMI wants us to comply with? So that's just I think there's, I think we're just sort of looking at it slightly from a different perspective. But so from looking at it from that perspective, I'm a little bit more comfortable with something you just said, which is that the primary care services are excluded from the shared savings. Because one of my other questions is, what if a hospital system was trying to invest heavily in preventative services, increase their utilization. We have significant challenges with access to care in Vermont. I don't think we have nearly the problems that other states have with, overutilization. It's very focused in a few areas here that increasing access might help. So if a hospital system tried to really improve access to care and blew through their Medicare budget, and could that cause harm to the hospital's sustainability or increased need on commercial revenue by trying to improve preventative services?
And I think when Shule said primary care, Shule, I think, did you mean the enhanced primary care
Payments.
payment? Yeah,
Yeah.
yeah. So that average $17 PM, I want to make sure we're clear about that. That would not be included in total cost of care calculations. Yeah. So I just want to make sure we're clear. And and similarly, the transformation funding for hospitals.
Okay.
Okay. Yeah.
So if there was increased primary care spending, that would count towards the total cost of care calculations.
Yeah, not counting the enhanced primary care payments that Medicare is going to provide. Yeah. They'd be looking, at claims basically.
Okay.
Yeah.
But Shule, what did you think about? I mean, is that, I could see these scenarios where a hospital could get themselves in financial trouble by trying to really improve preventative care too quickly. Or does the annual adjustments, does that, if a hospital spends a lot more money on, go ahead.
I don't think so. I think if they invest in primary care, open new clinics, right, they should prospectively get additional adjustment for new services. And eventually, not on the same year, but their utilization would come down, right? So they need to, I don't think there is that much of a risk.
Went up? So, so say we have people who aren't getting care, and then they get care, and now you're having increased utilization. People who go to primary care providers who haven't seen a primary care provider tend to get more lab tests, more imaging, because they've just not had access to care. So would that scenario then could lead to an increased total cost of care, but it might increase the good care, increase good care. So if say a hospital system opens a primary care clinic with 10 primary care providers, and you have all these new patients that come in because there's really challenge getting primary care access right now, and those patients then get lab tests and imaging, the total cost of care is going to go up.
But those patients were, in the historical terms, ending up in EDs and inpatient setting, right? So if they don't have access, that's the dynamic that we are trying to break. Short term, there may need to be adjustments, but I think that's the right thing to do under global payment. Pat, if you want to add anything to me, I don't see.
Yeah, I was going to say the same thing. Some of the results of not getting primary care, it's pretty quick, people do land in the ED. I possibly some of those potentially, ambulatory care, sensitive condition, they may end up inpatient. Once they get primary care, they're less likely to land there if their conditions are managed. And that, that's not a year's thing probably, but you're the physician. So I'll ask you, it seems like while there may be a delay to some degree in seeing that lower utilization, if they have a medical home, the ED is not their medical home anymore. So.
Yeah, my understanding of the literature, people who don't have access to primary care, when they get access to primary care, the total cost of care goes up. But That's just my understanding of literature. There may be newer literature that's more, that's probably
For
10, 15 years old.
Right, for individuals, for them, yes, but if you think about population health, how much of that is because it's going to reduce their historical, right? So for an individual, you may be right. Like if you're thinking one person, I had one visit, now I'm going to have 3 visits. I'm going to have EDs. At the end, on the individual side, I think the question is at the population level, what will happen to the total cost?
That's my understanding is on the population level. I would never suggest, by the way, that we don't provide primary care for people. I think having primary care services is the ethical and right and humanistic thing to do. But my understanding is that people are not getting primary care, and now they are getting primary care. You do have an increase in total cost of care because now you get treatment for all the diseases that they weren't getting treated for before. Better quality of life. It's more ethical. It's the right thing to do. But I don't know if my understanding of the literature, at least, and I could be, and I am not a primary care physician, is that people are truly not receiving primary care. That when it gets into you do increase the amount of treatments, you increase the amount of testing, and these are actually good things to keep people healthy and keep people healthy and living better quality lives longer. I had one, I guess just one more question, which is kind of like why save the bomb for the last question, but it was supposed to be earlier, but we kind of end up going in this direction, which is, you've been looking at global budgets for a long time, and global budgets has the potential to solve a lot of problems. But what's the downside to global budgets? Where are the pitfalls? Where do we need to double our efforts to not get into traps if we do global budgets?
Transformation plans. Sorry, Pat.
Yeah, I'll start and then Shule jump in because you have way more experience than I do with global budgets. But, the first thing that comes to mind is, the need to monitor utilization and just, make sure that people, we want to reduce avoidable care for sure. And we want to ensure that care is in the right setting, but by the same token, we would want to monitor for utilization and trends to make sure that people are we're not seeing big changes in access to care. So I think that's really important. That's why we added sort of that 4th category on the performance framework around monitoring. Go ahead, Julie.
Jessica's point about access measures, right? So that's a place where we really have to be advancing the way we measure access and quality. And I mentioned transformation. We focus a lot, and I personally obviously focus a lot on the financial side, but believe it or not, that's the easier part. The issue is once they have the global budgets, what the hospitals are going to do and what is the commitment from the leadership and the staff. So that's the place where we need to focus and invest a lot of effort, understanding, helping, and working with the hospitals to really make things happen on the ground. A lot of the physicians, clinicians don't know how the hospitals are getting paid, right? So at the end of the day, it's about changing the practices where we need to spend a lot of time once we remove the financial barrier from doing the right thing.
And I would just add paying careful attention, continuing to pay careful attention to the continuum of care, post-acute care. How can we use this model to support post-acute care and preventive care too? So.
Thank you. I think only Robin's left, but I don't know if Robin even has questions because she's like the master. Oh, Tom. Sorry, I apologize, Tom.
So let me step in just for some timekeeping because we have to get to Dr. Hamre. So I connected with Member Walsh and Lunge, and they have kindly agreed to hold their questions, and a lot of our questions I think covered some of theirs, and so I think they're kindly going to agree to wait on theirs. We also have a couple questions from member homes that were for executive session. We're going to wait on those as well and do those the next time Pat and Shule are back. So I apologize for that. There's a really robust discussion that has been really informative. So I didn't want to. So unless Robin or Tom, you need something today. Okay. All right. So and I did want to get public comment in. So thank you to Robin and Tom for recognizing the time issue. So I will open up to public comment. If anyone has public comment, please use the raise your hand function. Ms. Aronoff, nice to see you. How are you? Please go ahead.
Hi, good afternoon. Really quickly, the next time you guys have one of these presentations, and I think they're just so wonderful, and we, by the way, love the AHEAD model because equity, equity, equity. I would like to know the perspective of the Green Mountain Care Board as to whether or not you guys see yourselves as becoming a signatory like the Green Mountain Care Board was for the all-payer model, or a regulator. And I'm just trying to get a handle on who's doing what in the healthcare space, especially as people are discussing S211 and things like that. And so I just would love to hear the Green Mountain Care Board's perspective on where it sees its role in this future model, not for now, but as an agenda item. And I don't know, Pat, if Green Mountain Care Board would be a necessary signatory, or we don't have to go there. But anyway, I feel like when you guys were a signatory before, there's just been a lot of role confusion as to whether or not you guys are reformers and promoters or regulators. And I think there were a lot of goalposts moved to support the success of the all-payer model by the regulators. And as someone who was a skeptic and still am, and concerned about how Medicaid was sort of hijacked to support the all-payer model, I just would love to know what you're planning to do going forward. So food for thought, and thank you so much for spending all the time. I thought today's discussion was one of the best healthcare policy discussions I've heard in Vermont in a really long time. I just thought it was fantastic and deep and rich. And thank you, Pat and Shule, for all the work you're doing, and the Green Mountain Care Board for all your robust questions, and onward.
Thank you for saying that, Susan. And obviously, Pat and Shule are real experts. I will just note that probably our two biggest healthcare policy wonks on the board didn't even get to ask questions. So that's high praise. So thank you for that compliment, because our big guns were saved today with their big health policy minds. And I would just say, to briefly address your questions, we can get to others. I think some of the role of the board questions may be discussed potentially by others, or maybe even us, during the S211 discussions. I think there's a hearing notice. I know there's a hearing notice for Friday where some of that could be topical. The other thing I would point out is I think that the NOFO may have details on some of this. And then the last piece I would say is that the Care Board's role and what we do is assigned to us by the legislature. So our role in this is to collaborate with AHS. So that's where we fit in and what we're doing. And we are decidedly a regulator as well, of course. But I appreciate the comment, and it's been a topical discussion since I applied for this position, and I think it's a good one to have. All right. Any other questions or comments? Walter, it looked like you came off of mute, but I don't see you, and you usually pop up.
Oh, yeah. Hey, I apologize for the noise. I'm at the State House and a big party just descended, so I'll keep it simple. I just wish this could be so simple all the time. I mean, I've been listening to it for 3 hours. My God, why does everything have to be so complicated? Keep it simple.
Well, I think there's a lot of value to that perception. Enjoy the State House party today. Any other comments or questions? Oh, sorry, go ahead. Okay, anyone else?
Chair Foster, can I just highlight the schedule for the next time we're in front of the board on this topic? It's scheduled for February 21st. And I am in the process of sending an email asking to extend that time of that meeting or the agenda item to be able to sort of allow for more discussion as needed. That will likely be the last time we're in front of the board prior to submission, just given the last couple of weeks prior to the notice of funding opportunity submission. And so I just want to flag that we'll make it a longer agenda. We'll give it more time, but we'll be back on the 21st.
Great, thank you. Okay, you guys are doing a lot of work, so thanks for taking time out of your days to help educate and teach us, Pat and Shule. Thank you.
Thank you.
All right, we will not skip a beat here and turn to Elizabeth Sutherland, Dr. Bruce Hamry, and Marissa Melamed. Thank you for waiting.
Marissa, I can't hear you. Yeah. You're on mute, Marissa.
Can you hear me now? I had the double mute going on. Okay, can you see the screen? Yes, great. Okay. So I'm going to try to keep this short and hand it off to Bruce and Elizabeth, but just for some background, we're here today to get an update on the Act 167 Community Engagement Update. First, again, my name is Marissa Melamed, and I serve as the project director on the Green Mountain Care Board staff for this project. We have hired a great team to do this work. We are through phase 1 and into phase 2 of the project. So it's a good time for an update. And we want to hear some of the things that have come up on the road. Let me move ahead here. You've seen this slide several times before. It's always to keep people oriented to the several sections of Act 167 or the several work streams. I'm going to introduce the Oliver Wyman principals that we hired to complete this work, who may already be familiar to many of you, but we have Dr. Bruce Hamry and Elizabeth Sutherland. Dr. Hamry is the leading partner on the project. He's a clinician with over 50 years of experience in healthcare leadership, in healthcare systems and transformation, particularly in rural hospitals. He's also familiar to many of you through his 3 years of experience in Vermont with COVID data modeling and health services wait time report. And he is joined by Elizabeth Sutherland, who is an expert in examining health disparity and overcoming health equity barriers. And they have been leading all of the meetings and design and development of this project since we began in August. So that's when the contract started. The first several months ran through several months of engagement plan development. That was a robust process with extensive stakeholder engagement to put together a plan for how Bruce and Elizabeth and team were going to go around the state and talk with stakeholders and everyone in the healthcare landscape to glean information on their experiences in the healthcare system. In October, the project moved into the phase 1 round meetings, which were an extensive and statewide series of listening sessions targeted to community members at large, providers, and members of diverse populations. Those meetings ran from October 24th through November 21st. We're going to see the numbers on how many people were